Hello and welcome to the model walkthrough series. This is the second session in a series of 4. The first session covered the emergency department model and is available to view on our future NHS collaboration platform. We are covering a number of models recently developed by the demand and capacity team and how these will help with service and operational planning in this webinar series. Today, we're going to be covering the Community and Mental Health Demand and Capacity Offer and the Discharge Hub Staffing model. So today you have myself, Matthew O'Reilly from the National Demand and Capacity team, and Kate Pound from the Emergency Care Support team. I will introduce the Community and Mental Health Demand and Capacity Offer, the Discharge Hub Staffing Offer, and Kate will give some background to the collaboration, the context, and the practical application of the model and the benefits that have been derived from this. So some background initially to the model walkthrough series. We'll be showcasing 4 new demand and capacity models and how these can be used to support operational service planning. We are not covering the principles and fundamentals of demand and capacity planning. However, you can access this and additional resources from our website. If you do have any questions or queries relating to demand and capacity planning, you can email the demand and capacity team at england.demandandcapacityproject@nhs.net. This series represents a collaboration between the demand and capacity team, the clinical workforce productivity team, and the emergency care improvement support team. I'd like to thank everybody for taking part, for their collaborative effort and for sharing experiences. So today's session is the Community and Mental Health Demand and Capacity Offer and the Discharge Hub Staffing model. Last week's session covered the emergency department model, and a recording of this can be found on the Demand and Capacity Future NHS workspace. You'll see on this slide that future sessions will cover the urgent response model and the caseload model, which is a model aimed at community and mental health services where patients are on a caseload for a period of time, or can be used flexibly to cover pathways, treatment groupings, localities, and various other patient-defined groups. So today's session will cover the launch of the Community and Mental Health Demand and Capacity Support Offer, an overview of the Discharge Hub Staffing model, and the practical application of the model. Community and Mental Health Services Support Offer. I'm delighted to be able to launch the Community and Mental Health Services Support Offer in this webinar series. This resource is available from our Future NHS workspace. The link is on this slide, and it expands the demand and capacity offer that is currently available. The resource gives an introduction to modelling in community and mental health services, details about getting started, resources that are available, and covers some of the difficulties encountered within community and mental health services, of which data quality may well be one of them, and also gives a guide to using some of the outputs. So we aim that the resource pack and offer helps you to get started with modelling in community and mental health services. We do acknowledge that the variation between services and often within pathways does make it difficult for many organisations to get started with their modelling. However, there are patterns to the care provided and common themes which, through scoping and pathway mapping, can give a useful start point. This may be triage or first appointments or reviews. Our advice is to start small with what you can scope and what you can count. We know that access to data and data quality can sometimes be difficult, so do use evidence-based assumptions where necessary. But remember to always document these and to review and agree any assumptions with key stakeholders. So start with small steps and build from this. Build on the knowledge and experience that has been gained. So to support this, we've also developed a dedicated Future NHS Community and Mental Health Resources section of our workspace. The link is on the slide. Do have a look at the content here. We think it is very useful, and that by consolidating resources in one place will be very helpful. So the components of the offer and the workspace on the Future NHS platform are learning materials, including many links to training and useful webinars, models, of course, and you can find the links to the more established models, such as the core model, which you may have seen presented previously, and the new models that we are featuring in this webinar series. In sessions 2, 3 and 4, so this session, the Discharge Hub Staffing model, and in the future sessions, the urgent response and caseload models. Other components include case studies. So we feature case studies that we think are relevant and of interest to community and mental health services, which may give you ideas and helpful hints with your demand and capacity modelling. We include a knowledge share, so a space to share key documents and resources. And if you have any resources that you think might be useful to the wider community and mental health network, then please do share those with us, and we can share them on the platform. We have a peer-led working group, and pre-pandemic we had established this working group within the community and mental health sector to facilitate networking, development and testing, sharing resources and sharing presentations. We do aim for this group to be active again as soon as time permits for our participants. If you're interested in getting involved in the group, sharing resources or knowledge, then please do let us know. So moving on, the Discharge Hub Staffing model. I'm delighted that in today's session we are featuring the Discharge Hub Staffing model, one of the 3 new developmental models that the demand and capacity team has been involved in collaborating with the development of. And I will hand over to Kate to give some background and to outline the service model that this has been applied to.
Thank you, Matthew, for that introduction. So if I tell you a bit about the background. So I was working with a large organisation and large system, and obviously, you know, there was lots of things coming out because of COVID, and we had the new discharge policy, which talked about the fact that we wanted to have a single point of access. You know, we wanted to have one space where all the staff would be out together, and we'd create a new rhythm of the office where people would learn and support each other to improve discharges. But the big question that we had was, how big's the office got to be? How many staff have we got? Because it's really important that we understood this, that we understood how many staff we were going to be, because we had to follow COVID rules. We had to create a space that could take social distancing. So, you know, this model was developed at really at pace because it was an urgent issue. We needed to move quickly. So we contacted the demand capacity team and said, you know, this is a problem, can you help? And we created some collaborative work together, and this involved the acute and the community and social care. So what we did know was the work from John Bolton, and he talked about the services that were required in the community. He talks about the percentage of patients in hospital who will go out in pathway 0 and those that will go on pathways 1, 2 and 3 and the numbers. And this very much focused on what resources would I need in the community to support discharges. So making sure that all patients could go to the right place based on their needs at that time. And this would offer support for patients to ensure they would be home first and they would only go into a care home setting if it was required. But what this model doesn't do is tell you about how many staff you need to actually manage the discharge processes to prevent delays, and then things would run smoothly and we'd get patients out without delays. So this was the question that we went to the demand capacity team, and this is a really simple drawing, but it really helped to clarify when we worked with the team. So this was the first piece that they did with us. So right, let's just visualize what it is. So we've got all the discharges in the hospital. Out of those discharges, 50% are pathway 0. So those are the patients that we don't touch, but those are the patients we don't need any support. But the others are patients that are on pathways 1, 2 and 3, which we do support through the single point of access. And then we took it another step. So how many of those patients are purely the work of this team, that the work of the single point of access and the local teams? And we had the group that was out of area. So we focused on those that were only in this one system. And it really helped to clarify the numbers and how many people, and that was the reason why we just focused on that. So the Discharge Hub service model involved different teams. So we had the in-reach team, so those staff were actually based at the hospital, and they would go and work with staff on the wards and talk to relatives, and it was very much, they did the fact finding to understand each need of the patient. A hospital has to describe patient needs and the community prescribe based on those needs. They prescribe what's required to support discharges. So as I said, the hub model has the in-reach team within the hospital, and then we also had the referral team. So that was the single point of access in the community. At that point, it was an isolated team, but it had the community teams, the referral team and the support at home team there, and the rehab team. But we also had the social care team, who again were in a different space. They weren't all sitting together. So to get the service model, we had to understand the needs of each of these groups and understand what the demands were of these groups from day to day. So I'm going to hand back to Matthew, so hopefully we can understand a bit more of how this works within the demand capacity tool.
Thank you, Kate. So the Discharge Hub Staffing model is one of the new developmental models that are now available on our Future NHS platform. These have been developed in collaboration and with involvement and feedback from stakeholders and continue to be evolved. This model was initially developed to answer one question for one service following Kate's approach to the demand and capacity team. Further development and new functionality will enable the model to support multiple questions for multiple services based on feedback and engagement. You can see on this slide the three models highlighted in green: the urgent response model, the Discharge Hub Staffing model, and the caseload model, which are the focus on sessions 2, 3 and 4 within this webinar series. As we've said previously, this model was developed and implemented at speed and supported delivery of benefits that were needed at speed. So the Discharge Hub Staffing model The model is more simplistic in terms of inputs required compared to, for instance, the core model that you may be familiar with, or the emergency department model that you may have seen in the first session of this webinar series. On this slide, you can see the number of medically fit patients ready for discharge that require resource from the Discharge Hub. We can see trended data displayed over time and by day of the week. You can see that the pattern is relatively consistent across the week, but certainly there is a reduction on a Sunday. This slide shows the referrals into the hub. The number of referrals received by the Discharge Hub are displayed split between the local borough and out of area borough. You can see that there is a significant proportion of referrals received by the out of area borough patients. The referrals are displayed over time, and you can see that there is variation on a daily basis. The next input that is displayed is the average duration of resource required to support each patient from the hub for in-hospital or in-reach work. You will see that there is a figure highlighted in yellow, which is the average resource required. And this differs, and will be shown on subsequent slides, for the hub work for health and also the hub work for social care. Also shown here is that this gives us a conversion to time and ultimately full-time equivalents required. At present, this is a crude calculation, but the next iteration of the model allows this to be adjusted based on locally defined parameters. The outputs also allow us to view required capacity by day of the week, and this helps with planning. We aim for the future iteration of the model to also include a breakdown of this by hour of the day. You can see here that there is variation on a daily basis, and this is particularly noticeable on a Sunday. This slide displayed now shows the model inputs for the hub work for health. It's a similar view and similar methodology as for the in-reach element of the service, but a different assumption for the time required for dealing with each of the patient referrals. You will also note that there is much more variation in the required capacity per day and a significantly reduced requirement at a weekend and particularly on a Sunday. This is also the case when we look at the hub work supporting social care. Again, there is a different assumption for the time required for each patient's referrals, but a similar methodology applied to calculate the required capacity. As I mentioned previously, the model was developed and implemented at speed and enabled benefits to be achieved, and we will hear about those from Kate shortly. We recognise there is further potential and development and would welcome anyone that is interested in testing some of the new functionality or providing further feedback to get in touch. Updates will be provided via our future NHS demand and capacity workspace. We do think, though, that the model can be used in alternative settings, such as that being described here today. And some of the examples that we have been in discussion about include triage requirements, particularly within allied health professional services, whereby there is a requirement to identify the capacity required for delivering the triage function. I am now going to hand over to Kate to tell us about how the model was used and the benefits that have resulted from using the model.
Thank you, Matthew. So as I said earlier, I was working with a really large system. It's a big acute trust, and they were under massive demands because of COVID, and they also had a lot of complex needs for their patients. This model was just, it was the starting point because we really needed to change things at pace. But what we were finding, because of the scale, the size of the groups we were working with, and the difficulties with everybody being in their own hubs, the staff groups, we were finding that there was a lot of reworking. There was re-storytelling about patients' narrative, and what that meant was that the retelling of the stories, there were variations, and it led to confusion, and it then also led to delays whilst we sorted out those confusions. And also, because of that confusion, it also led to some difficulties in relationships, as you know, there was an awful lot of tension sometimes about, well, why, who, what, and that was difficult for staff. You know, we really believed that if we could get a single place to work together, that we'd create a new office environment. We'd be able to allow the narrative to be told in once and in one space, that because everybody would be in that same space, and it would really help relationships, and it would also reduce the time required for updates and for the provision to be agreed and arranged. We really felt that it was important to have this single point of access team, you know, one space and this place where there was the ability to work together. However, we did need to make it COVID safe. We did need to take into account the needs of the staff, and to make sure that it was appropriately resourced and it was kept in a safe for the patient, for the staff to work in. So one of our things that we looked at, and we had the ideal pathway designed for discharge processes. This pathway is based on the discharge policy, and we also had the local pathway. So we looked at the local pathway and how many steps were in each of them, where the reworking is, and then add value. So it became more of a value stream map. And then we compared it to the place that we want to be in the future, the single point of access, the future state, and looked at where the opportunities were. But it's important that we did this so we could understand, you know, how much time was required for each of the pathways. If you're a discharge lead, we looked at the average time that we felt that they believed that a patient would take. And yes, we did work from the extremes, because some patients would take 15 minutes. Another patient might take several hours throughout several days. So it was a crude measure, but it was a really good starting point. It was taking the average meant that we had a really good starting point, and this allowed for conversations to open up. It allowed for us to think as well about areas for redesign. You know, as we saw earlier, there was less resources at the weekend, and there was less referrals as well. So that open conversation, why do we have these differences? Why do we have these variations? And, it relates to us, I'm sure you're all aware, issues around lack of access to nursing homes at the weekends, or perhaps less care packages. And, social care would be staffing to what their facilities were, whether they're, could they get care packages? So if they can't, why put, staffing at the weekends? And it just really opened up all these questions about what we could do best for our staff and what we could do best for our patients, and working together. And I think it was really exciting doing this piece of work, because it really improved the group looking at areas for improvement, and they were able to take a quality improvement approach to looking about how we could improve it and what we could do, and understanding the why. So we had benefits, and we understood the daily variation. We could see it. we could really talk about it. And, you know, it was surprising really because we didn't talk about this very often. We didn't look at the data. And with that, we also understood the high volume of patients that were coming through the hub that were out of areas. And this really, for me, opened up discussions, you know, how do we support out of area patients? You know, should we have commissioning questions with some of the CCGs that are out of areas and understand how they can help us help the patients? You know, should there be, whether it's commissioning needs, but it just opened the door to bigger questions, but with evidence. And the other elements that it looked at, that it helped to support a business case. You know, it helped us to identify what the roles were and where we needed to put those, and we're able to write business case from it. And the other area was, of course, it built relationships. It meant that we were talking to each other, and we, you know, this is something that's ongoing, it's growing, and there's still much more work to be done. And the final bit, which I haven't included in this slide, was the tool also opened up the opportunity to think about predictions, because we could change the level of patients referred in. And if we felt that, you know, there was going to be an increase because of, say, COVID or winter pressures, we could adapt the model and then predict and see what level of staffing we think we'd require if demand increased. And that hadn't been done before. That was kind of like looking at new ways of working. And it just led to that better understanding of what the variation is, what does the data say, and how we could improve areas.
Thanks, Kate. I think it's really interesting to hear about some of those benefits that have been achieved and the way that the tool has been used. I wonder, reflecting, how effective that you think this has been.
So, I mean, it is, you know, as we talked about earlier, it is a, you know, could say a crude measure, but it's a starting point. You know, this was done at pace, and, you know, I kept on saying we need to keep this simple. You know, we need to keep it really simple, because people haven't got time to taking in non-data collections and, you know, doing it. We just didn't have that time, we didn't have that luxury. So this was a starting point, and, you know, it helped to inform the decisions. You know, yes, there's loads of areas that we could improve on, but, you know, it was that starting point. And I always talk about, you know, discharge is a team sport, and, you know, this really highlighted the need for that team sport, and how we work together.
I think that's a really interesting point, isn't it? Because I know in a lot of areas, other organisations, voluntary sector organisations, are becoming more and more involved in that.
Yes, absolutely. And understanding the flow and the demand is like the first question. And then we can understand where the gaps are in our services and how best to adapt and create new ways of working with areas such as the voluntary sector. I always think, you know, I say it's a team sport. I always imagine, you know, it's a bit like a game of rugby where the ball gets passed from person to person, but, you know, there's the strategy, there's an understanding, there's knowledge, and, you know, when they throw the ball and magically somebody's there to pick it up and hold it. I think that's what we need to be like with patient care, with the discharge planning. You know, remember, it's a team sport.
Thank you. That's a really good analogy. So obviously you talked about the business case being developed. How did the commissioners view that business case?
Well, yeah, we had quite an urgent case to actually produce this, because we had a timeline when we had to get the business case done. And I worked with a senior manager in the team, and it was brilliant just working with her. She was so helpful and just really somebody you could rely on getting stuff done. And what was really important for them was improving the experiences for the patients, because you know, it was not right that patients wait for discharge because we don't have the facilities available, or, you know, the staff are under so much pressure to get patients out. And also from the staff point of view, you know, it was really important we improved the experiences for staff, because, you know, it's quite a lonely place being in the discharge team. You know, there's lots of areas that are depending on you getting this right, and there's a lot of pressure, and it's a very hard place to work. So it was great to work with her, and the commissioning team, you know, took on the feedback, took on the business case, and, you know, jobs going out to add, and they're moving forward. But it's a starting point.
That's great, thank you. So it's been really, really interesting to hear about that practical application and the benefits that have been achieved. To wrap up today's session, we've covered the community and mental health demand and capacity offer and resources that are available, an overview of the Discharge Hub staffing model, and heard about the practical use of this. This has been the second week of our series. The offers for weeks 3 and 4 are shown on the slide, and you can find more information and register using the link that is shown on the slide. I'd like to thank you for your time viewing this recording. If you'd like to find out more about the work of and stay connected with the elective and emergency care improvement support team, you can follow the links on this slide. So there are links to Twitter, YouTube, Facebook, and also the future NHS collaboration platform. Kate's Twitter address is also on the slide should you wish to follow Kate and find out more about the work that she's involved with. If you'd like to stay in touch with the demand and capacity team and find out about our other models and resources, you can visit our website. You can sign up to our newsletter bulletin, and you can also join our future NHS collaboration platform. You can follow us on Twitter. That's myself at Matthew, and it's OREILL20, at Mohanty Ash, and at little_Lunston. And the hashtag is Plan for Patients. Please do get in touch if you have any further questions or queries regarding this webinar or any questions about demand and capacity planning in general.